Esteemed colleagues, distinguished guests, it's a great honor and privilege to stand here as the moderator of this prestigious dental conference. First and foremost, I'd like to thank ADEC for hosting the largest dental conference here in the world and for being our gracious hosts. I welcome each of you here to this gathering of brilliant and dedicated professionals in the dental profession. Implantology is a rapidly evolving field which is at the intersection of medicine, science, technology, and art. The theme for this Ritter Forum is Rebuild, Regenerate, Reconstruct, a Path to Success. And today we are not just here to discuss some techniques and procedures, we're here to explore the very essence of transformation and innovation that dental implants bring to the lives of our patients. I want to extend a warm welcome to our distinguished speakers. Their expertise and insights will enlighten us and challenge our way of thinking. They're truly committed to staying on top of the latest advancements, and their experience are going to be shared with us here today. To our attendees, I welcome you here to be part of our Ritter family. I encourage you to actively participate in the sessions, ask questions, and engage in the networking opportunities here that we're going to provide you with. So let this conference be a source of inspiration, innovation, and friendship. Thank you, and let the Ritter Dental Forum begin. I'd like to introduce my two good friends, Dr. Alessandro Agnini and his brother, Andrea Agnini. They're both from Modena, Italy. And Alessandro Agnini is, his specialty is perioprost, and he is the past president of CIPRO, which is the Italian Prosthetic Society. Both brothers are co-authors of the book Digital Dental Revolution, The Learning Curve, and the other textbook, Digital Dental Revolution 2.0, Clinical and Technical Approaches in a Modern Clinical Reality, which is edited by Quintessence. Ladies and gentlemen, I present to you the Agnini brothers. Take it away.
Thank you. Thank you, Nilesh. Thank you. Thank you for the kind introduction, Nilesh. And we want to thank the invitation, all the Ritter team, Natalia, where is Evgenia? Evgenia, and Basil. So Andrea, our challenging topic, and yes, we know when we lose two dental elements in aesthetic area is a very challenging, is one of the most challenging situation to face, and we will try in our lecture to understand surgical, prosthetical, and biological aspect to deliver a good and long-lasting aesthetic result to our patient, Andrea.
Yes, we should not forget about also the fact that there is also a digital rationale besides the sinusitis of my brothers. And so everything that you're going to see today is also embedded in this last publication that we have done together with Christian Kochman, which is going to enlighten you later during the day. And our website and our Instagram page are always open to you, to all the questions that you will have, and you can find us also today during the day, and you can stop us and questioning us on every aspect that we will discuss about.
And so the second volume came out when?
Last year. So Alessandro, we need to speak about aesthetics, so I think we should at least at the beginning, describing what is aesthetic all about.
Yes, in the state of health, we know to reestablish, or to have, not to reestablish, to have a good volume of interdental papilla is related to the good gingival incisor embrasure, a good teeth proportion, Andrea.
Yes, but let's do one step back, and because we were teasing you, because actually this was the initial situation of the patient. And actually you can see that everything about the white and the pink aesthetic balance here were off, because soft tissue is not there, teeth proportion are not there. So what do we need to do? What is the first thing that we need to address? Not only the white, but probably also the pink. And if we do it together, the teeth is going to be even better.
So we need to reestablish the root the root profile at the lateral side and reestablish the good proportion in the aesthetic area.
And doing it together, blending the white and the pink together probably is going to be like the best combination. The peri-pros combination at the same time, whenever you have the opportunity, probably is the way to go.
So it's very important to know very well the protocol, the surgical and the prosthetic protocol, and blend it together to leave to leave a space for the papilla during the healing phase.
In fact, we need to speak about, we are in an implant forum, but you see that we have a 17 years old female patient, so we should not forget that we also have this kind of arrow in our portfolio, which are like 2 Maryland bridges, which are like done together with a coronary repositioning flap with a connective tissue graft augmentation. And what was telling you, Alessandro, was the key. Prosthetic management is all about like shaping the soft tissue. And how to do it?
Yes.
Leave the space. That's the key that Alessandro just told you.
Yes, and remember, we need to face a young patient. So remember, not only implant, but also the prosthetic solution, Maryland bridge. But before deliver the Maryland bridge, you need to reestablish the volume.
And then you have to just let Mother Nature do its job. And you see that this is the white and pink blending that we were talking about. And we will discuss and we will see that most probably is the pink which is optimizing the white.
Yes, and if you choose the correct material and if you treat in correct way the surface of the material and also the teeth surface, you can cement very well the Maryland bridge.
And you can get like a 17 years old or actually 19 years old follow-up like this case. This is exactly what we aim to, long-lasting, aesthetic, predictable restoration. And this is very important. These concepts that we have just discussed are very important, especially when we are facing the aesthetic zone, when we have cases such as this, which are showing the critical interfaces. And so before touching the patient, we need to have very clear in mind this diagram, these guidelines, which were published back in 1990.
Yes, this is the milestone of the Salama articles, no? The milestone of the literature.
And we need to understand that there are different kind of scenarios.
Yes, give us an average of the indication. Look, an average of the indication of the amount of the soft tissue papilla in the space.
And why is that? Why is that? And why we showed you a tooth pontic site? Because we want to play with you. Because we started with the most simple case. Because it's the one that is the most favorable one. We will discuss also about the implant site. And why is this? Because, as we were mentioning at the beginning, biology gives you the answer. Biological width is a completely different environment around an healthy tooth and around an implant. And we will see that there are different implants, bone level and tissue level. These will make a difference as well. And what else? There are many ways to go to Rome, but what is important is that there is one way that suits better that specific anatomic scenario. We will discuss all of these techniques today, but what counts is the way you are managing the soft tissue and the provisional restoration. And if you do it together at the same time, thinking biologically, then probably that's going to be...
So different case, no? Implant pontic, implant pontic, plus pontic, tooth plus pontic, implant plus tooth, implants plus implants. So it's very important, I repeat this concept, it's very important to link the good protocol, surgical and prosthetical.
And formulated diagnosis, because the diagnosis is one, and this will guide you through the treatment plan the treatment plan decision making. So the outline of today is that we need to speak about the enlightenment of the peri-implant papilla. So first of all, is there a problem about it? And what is, but I'm telling you already, what are the solutions, because there are many different solutions. And we will try to give you our insight, our take-home message of it. So is there a problem, Alessandro? When we are dealing with a critical interface?
There is a problem. Is there a problem? There is a problem.
Because no matter what eye or low smile line 90% of the people, if you take a 45 degrees pictures, they're going to show you their interdental papilla.
So
More or less, but they're going to show you.
So we need to look the patient not only in the front, but also in the profile situation.
And
to understand the exposition, the interdental papilla exposition.
And if we need to reestablish a papilla, then we need to know what are we going to establish. It's a papilla between centrals, it's between central and laterals, it's between canines. We need to know how much should we reestablish. What are the aesthetic parameters? And the literature is coming to give us solutions.
Yes, mesial and distal papilla are about equal in length,
but are different in terms of like, where are we in the patient's mouth? And literature is also telling us there are some milestones, some articles which are giving us guidelines, like the papilla article from Dennis Tarno 1992. Is giving us an average, but that can guide us through the treatment plan. Because if we need to leave space, how much space do we leave according to where the bone peak is?
Yes, bone peak contact point distance, tooth implant.
5 millimeters. That's the number. That's the average. It's an average. Remember that. It's not a golden rule. It's an average that guides you through the treatment plan decision-making process.
Yes, depend of the case, depend of the phenotype situation, depend of your surgery.
And these numbers is more or less like was confirmed by several other articles in the literature. This is a group of the CDP, which is the Italian Periodontology Society, which is more or less is giving us the same number. So keep that number in mind, because it will be helpful. And you see, is there a problem, Alessandro?
Yes, absolutely. So it's very important to plan all the aspects before start the surgery, to avoid this kind of mistake, of kind of aesthetic failure, to place the implant in correct position, to understand the soft tissue phenotype that we have in front, before start the surgery, before start your treatment plan.
So the problem here was the diagnosis and the treatment plan decision making. Absolutely mistaken the way you place implant. And in the aesthetic zone, 75% of the insuccess described in the literature are related to a misplaced implant.
Yes, look the position of the head of these kind of implants in the aesthetic area related to the gingival margin, the adjacent teeth, outside the line, Andrea.
So why digital is important? Remember, we are talking about surgical and prosthetic aspect, but also digital. Digital can help you in making a mistake in the computer.
Yes, and look at the amount of the keratinized tissue around the implant.
So the take-home message here is that probably this case can be solved. Yes, it can, but at what cost for the patient? Because don't forget that we have the patient in the middle of the treatment plan. Could be a nice case to showcase in a lecture presentation like today, but what about the patient? She finished 6 months before this treatment, and now she had to start again, and she had to go through multiple surgeries, through multiple sets of provisional restoration in order to reestablish the proper white and pink aesthetics. That was exactly the cause of the failures of this case. So yes, you can pass from a situation such as this one to a situation such as that one, but once again, at what cost? Due to a mistake in the diagnosis and in the treatment plan decision-making process. It can be done, but don't forget that we have the patient, because here Alessandro had to go through multiple surgeries.
Yes, remove the old implant, re-establish the correct volume, manage the provisional restoration, and wait for the healing phase. Long time to deliver a correct final situation.
So re-establish the white and pink, but this will require time, cost, morbidity for the patient, and clinical skills. So digital is a pivotal part of your ball game, because gives you the opportunities, the more the case becomes complex, to diagnose and plan. Because if you make a mistake in the computer, you can solve it. If you make a mistake in the patient, you need a lot of clinical skills, and you need that the patient stays with you.
Yes, today we have the technology. We have the possibility to place several files in the same platform and plan in a relaxed situation the case. You have to do a mistake in the computer, not during the surgical phase.
So digital is already one solution. Remember, we were discussing about what is the solution. One of the solutions is the technology that gives you the opportunity to minimize mistakes, reducing and decreasing the time of treatment planning. And in terms of like surgical and prosthetic environment, what are the solutions?
And the solution there are probably is different aspects, Andrea.
Many different aspects.
So implants, biomechanics, and prosthetics, for sure, is one of the aspects. Hard and soft tissue biology, the other aspect, but also the PROST, emergence profile design and aesthetic characterizations.
And you will see that the PROST is gonna guide you through the surgical aspect, through the soft tissue management, because this is your aesthetic dimension, what you need to reestablish. This is your new aesthetic point of view. Buccal palatal volume in where the tooth is missing, but the root profile is there. So the buccal palatal dimension is your goal. How to achieve it? It depends. It depends on the case that you have to face, because we need to discuss about the nightmare of the peri-implant papilla, and it's one thing is one tooth,
yes,
completely different ball game, two teeth.
Completely different scenario, no? Anatomical scenario. One single tooth or two adjacent teeth.
And the solution, one of the solution is the way you manage.
Understand the literature. It's very important. Know the literatures. Increase your clinical skill to face these kind of cases.
And manage the provisional restoration properly. How do you manage the provisional restoration? There are several articles which are guiding us. This is one of the most famous one from Weisgold 2010, which divides the emergence profile of the restoration between the subcritical and the critical contour.
Yes, the subcritical contour area is located apical to the critical contour area, provided that sufficient running room is present.
What does this mean? You have to place the implant properly, because if the implant is too shallow, you don't have space for the subcritical contour.
So remember, if you use a bone level implant, you have a long running room. If you place a
tissue level
implant, you have a short running room. So it's very important to understand, to manage this kind of area in the provisional restoration.
And this concept can be explained even better, in our opinion, with this article, which was recently published by our good friend Ramon Gomez Meda,
our great friends,
and Jonas Esquivel, that is dividing the same area, but the subcritical contour now is the combination of the C plus B area, and then the critical contour is the E area, mainly. But what we were mentioning before, that the key is the way you place in the implant. And not only in terms of like depth into the socket, but also in terms of like mesiodistal and apicocoronally and buccopalatally. So the 3D implant position is the key. Because if not, you don't have the space to create a proper running room prosthetically that will drive the soft tissue at all. Look at this slide. You can see here different height of the implant placement, completely different space for the running room. Completely different space of the running room. And bone level or tissue level implant, that's for sure one of the variables that you need to take in consideration. But if the implant is too shallow, look the C and B area, how short it is.
The bone level shallow implant or tissue level. Change change a lot the emergence profile of your provision restoration.
So this is related to the apicocoronary implant positioning, but
there is other aspect, no? The relation of the implant bodily position and the emergence profile. Look the position of the implant in terms of palatal, vestibular and palatal situation, no?
And look also the inclination that you have, which depends as well from the socket.
So once again, use the technology to plan very well your implant position at the computer, okay? Place in the same platform the STL file, the project of the technician, and the DICOM file, and plan your implant in a perfect position related to this aspect.
But which kind of implants? Because that's another question. Which kind of implant? Platform switching, non-platform switching, flat-to-flat connection, conical connection, because also the implant design, it's another variable that you have to take in consideration. And what we can tell you is that platform switching is here to stay. So if you go for an implant which has a platform switching implant, that's another good solution, because platform switching is here to stay. Is another variable that can drive you to success. Plus, there is another variable. We have mentioned it several times. Bone level or tissue level? Where are you going to place the implant according to the design that this implant has?
Yes, bone level, tissue level. Different aspect of the bone related of the design of the implant and the position of the implant at the level of the bone or up to the bone.
And on top of this implant, what are you going to place? Because we should not forget that it's not just the implant, it's also the prosthetic components that you're going to place on top of the implant. Which kind of tie bases, if you want to do screw retain solution, do we have? Do we have like a slim, nice tie base, or we have like a fat tie base? Because if you're using the first tie base on the left side, you can place the implant perfectly, managing perfectly a connective tissue graft augmentation on it, or leaving a socket sheet, or leaving a root in the socket.
Different length of the body.
But
also.
that cuff will take space. So, as Alessandro just pointed out, different length is important and as narrow as possible at the level of the implant head, so you have space.
Yes, because if you use a bone level implant, if you use this kind of long body of the T-base, you place the connection with the prostate far away to the bone. Okay?
And so prosthetics is the key. But we should not forget that there are many, many ways to go to Rome. So which are the ardents of tissue biologically objectives? Here you see that there are many different techniques, but all of these techniques, they have one main goal, one primary objective, which is to achieve long-term stability of both the hard and the soft tissue.
But we have also the secondary objectives. Yes, the least number of the intervention, the least pain and morbidity, the shortest overall treatment and healing time, but this kind of second objective don't have to jeopardize
the primary one.
The primary one.
So we can say one thing, the secondary objectives are patient-related. So whenever we can, we try to do and to fulfill this because our patient will be happy. But if we have not in the right anatomic scenario to do an immediate placement, don't do it. Because you're going to jeopardize the possibility of achieving long-term stability of hard and soft tissue, which is your key. And what does depend on from the anatomic scenario?
Type 1, the perfect scenario, no? Type 1.
Ideal scenario.
The bone is there and the soft tissue is there.
The buccal plate is not missing. It's there. You just have to maintain what you have. So your effort should be oriented to maintain what we have. Type 3, completely the opposite. No bone, no soft tissue, loss of interdental height of the bone. So you need to reestablish a type 1 socket before go for the final. And type 2, challenging scenario because
it's difficult to diagnose.
Soft tissue is there, but buccal plate
is missing, related to to the pathological aspect or anatomical aspect?
It depends. And you need to double check it with the CBCT. So CBCT is mandatory to avoid mistake. So to sum up, type 1 objectives is to preserve, type 2 objective is to diagnose, type 3 objectives is to rebuild. Okay, just in order to give you some guidelines. And what about, we were talking about the bone, but what about the soft tissue? Because gingival phenotype can change.
Yes, because thin phenotype are mostly associated with an augmented clinical crown, scalloped gingival trend, and normally triangular tooth shape.
So probably not the best case to work or to start with. It's much better to work in a thick phenotype, okay? And so you need really to evaluate the quality and the quantity of the architecture, because thick phenotype is good, but don't forget that buccal bone thickness is 90% of the time less than 1 millimeter, even if you have a thick gingival phenotype.
Yes, it's very important also the quantity, the keratinoid tissue. The presence of the keratinoid tissue is very important to maintain hygiene maintenance for the patient.
So all these parameters are guiding you on when are you going to place an implant, because you can choose many times in where to place that implant. The same day of the extraction, you can wait 4 to 8 weeks after the extraction, or you can wait in a type 3, the classic delayed implant placement, 8 to 6
Another
weeks.
milestone article from by Hammerley, no, Andrea? Yes, type 1, type 2, type 3, type 4. Different situation, different scenario, different time.
But don't forget, the patient don't know about these articles. So it's very important also the communication with the patient. And so this is where also technology can help you out. Communicate with them so that in a case such as this, in where you have two different biological scenarios, the patient doesn't know. We know. So we need to explain them in advance that probably the two scenarios at the end of the implant surgery will look different.
Yes, because a post-extraction site, but also in a ridge, a genesis situation. And we know when we have to face a genesis scenario, we know that the passive erosion has not occurred. This is very important during the surgical phase. Remove little bit the bone to place in the position, in correct position, the head of the implants.
And now what you have to do to deal with the prosthetic phase. And the prosthetic phase, even in two different anatomic scenarios, it looks the same and the objectives are the same. Recreate a nice and smooth and adequate prosthetic running room to support the soft tissue. This is your key. So this is the analogical way, the traditional way. So you have like a titanium cylinder that you sandblaze and fillet. You place a piece of rubber drum to protect the socket or the wound, and then you have like an acrylic shell that goes into the place and the patient will bite down. So it gives you the exact position of the tooth. Then you wait for the setup, and in your lab you will create and design.
Yes, recreate the correct emergence profile design related to the literature. No? Remember a Weisgold article and remember Gomez-Meda article. So the first portion of the emergence profile must be very slim, very
narrow.
Very narrow.
Tips and tricks. You can use resin, composite, and PMMA and polish them properly.
Yes.
And because this is going to facilitate the epithelial attachment on their surfaces, but they must be treated with any varnish material, not even chlorhexidine solution.
So it's very important also to reestablish the contact point to have the correct position of the peak of the papilla, the hypertrophic portion of the papilla. So the contact point, but also smooth very well the surface of the provisional restoration, because the provisional restoration must be sort of the seal of the socket.
And all these concepts should be embedded in your brain, because technology is not going to change the way you are working. Actually, it's changing the efficiency of the way you're working, but not the know-how. Because here you have a lateral incisor. You see, you can do it and you can shape a provisional restoration emergence profile contact points, but you are guiding the mouse. And you are the one that, I went back. You are the one that are leaving the space in between the contact points so that you let Mother Nature do its job and fill that space, because we measure where we know where the bone peak is, and it's less than 5 millimeters. So then everything is going to fill up. So, and don't forget, of course, you need to consider the apical point of the contact area, not the coronal one, but just leave the space. Just leave the space, because at the very end, everything will grow back, and you can utilize digital solution through also in combination with the new innovative material, monolithic material, to finalize a lateral incisor such as this, where now the papilla are in the right place. So let's go back to the previous case, the agenesis of the lateral. Now we have discussed about the importance of the provisional restoration. And what about the peri-implant papilla? Why is important the provisional restoration? Because it's mechanically supporting that space.
Yes, because if you don't lose the clinical attachment of the adjacent teeth, you have obviously the papilla. But also it's very important to reestablish the contact point area with the provisional restoration.
And this is true for any different corrective therapies, surgical corrective therapies that you're going to utilize. No matter what you're doing, a dual zone and a surgical veneer grafting or a partial extraction therapy, the concept is always manage properly the emergence profile, manage properly the contact points, knowing where the bone peak is, and the soft tissue will grow down.
It try to compensate the natural resorption, 3D resorption after the tooth extraction.
And this is exactly what happened to this patient. Remember, one fresh extraction socket, one early delayed. You see, for the patient went home and she asked us, "Are you sure this is correct?" We were sure, but we
I don't know, but
to her before.
Probably yes, I don't know. If you don't lose attachment, remember, you don't lose attachment in the adjacent teeth, okay, and you place properly the head of the implant, don't worry. Wait the healing. You manage in right way also the measures profile provisional restoration, wait in the healing.
The worst mistake you can do here is to close that space. Even after 2 months, you see the papilla is not came back 100%, but look at 4 months, look at 5 months, the papilla is there. Look at 6 months, now we are ready to take an impression. And you can take an impression traditional or digital. We strongly suggest you to go digital because you have so many advantages. And this is exactly what we have done back in the days. That was 2013, one
yes,
of the very first digital impression and one of the first copy-paste concept, right?
Absolutely. All cases, copy-paste digital concept. Nowadays, all the cases is a copy-paste from the provisional restoration to the final restoration.
But what does this mean? You have the provisional restoration chair side, you can scan it. You scan it, you send to the lab will copy exactly the emergence profile that has been tested through the provisional restoration. This is the publication that we have done last year together with Christian Coachman and our team.
So the day of the impression, the day of the final impression, you take the impression of the provisional restoration in place, the antagonist, the bite, the target area with the scan body, and then you take the last impression is the scan of the impression scan of the provisional restoration, cioè sai to deliver the right design of the measures profile to the lab technician.
And you see here, the lab technician doesn't check the emergence profile, just copy and paste it, whether it's like checking on the shape of the framework, checking on the aesthetic characterization, the monolithic portion is all occlusal, the occlusal portion is all monolithic, and this is the final solution. So you see here, white and pink aesthetic, which are blending together for the success of this case. And you see, it absolutely is a life-changing therapy if it is properly done. This was the initial situation of this patient, and you see the day of the final restoration. But what what is the most important thing is the long-lasting predictability. Hard and soft tissue, stability. Remember, that's the primary objective. 11 years follow-up, everything is stable. And how do you check it? Not only with pictures. Now we have technology that gives you the opportunity to check digital quality control, which can be done.
Yes, you can superimpose different files at different time, so you can understand if you
Lost or not
soft tissue and volume.
Shrinkage or not shrink. And in an objective way, the patient cannot challenge a computer. They can challenge you, but if you show them, listen, it's not changing anything. So see you next time. And this is important, this concept. We have seen it in an immediate implants, but it can be seen in an early delayed because we didn't immediately load the implant here. We just place the implant, wait for the healing. Now we have a delayed approach. We do the dynamic compression technique. Concepts are the same, but look what is there. Leave the space.
Leave the space and wait for the healing and the soft tissue mature.
In this case, you need to wait a little longer because you need to give time for the soft tissue to enlarge and stabilize itself. And after that, once again, my suggestion, copy-paste. And this is the scan protocol that Alessandro was talking about. Upper arch with the provisional restoration in place, lower arch, bite registration.
Upper arch with the scan body in place, in high definition.
And the provisional restoration chairside scan. So the last two scans are the most important one. But why? Look, the high definition. Look how many triangles we do have in the fulcrum area, in the target area. So we are giving more information to our lab. Contact points as well. And look, provisional restoration emergence profile is copied and pasted.
So through the provisional restoration, we send the right position of our soft tissue. Don't matter if you have an implant crown or a teeth crown or Pontic side crown, you send through the provisional restoration to the lab technician the right position of the soft tissue.
And
this is the great advantage of the technology.
It's an imitation game now. There is no guessing. Imitation of the provisional restoration emergence profile. And then in this case, it's an old case, it's 6 years or 7 years ago. We were working with this company that didn't have like the screw channel, the screw angle channel. So we decided to go for a cement retain restoration. So also in the cement retain, the way your lab technician is designing the abutment, of course, should be oriented to give space to the soft tissue to proliferate, not to gain space out.
Narrow design at the level of the implant and the smooth surface and polished surface of the abutment before deliver the final restoration.
So also now, also here, also in this case, just be patient and wait. You see that the papilla were not there. Remember, the niton of the peri-implant papilla. Papilla were not there, but the contact point was there, the bone peak was there. Just be patient and wait, because the papilla will grow back and it will be staying there, especially if during the cementation you are utilizing a nice cementation protocol.
Yes, it's very important to place the cementation interface at the level below 1 millimeter the gingival margin, no more, to facilitate the cement removal.
And so you see 6 or actually 7 years follow-up right now. You see the papilla is there, everything is stable. So we were able to solve also this. But so far, we were just talking about one tooth. Now, when we have to deal with this peri-implant papilla, the central lateral dilemma is actually a real dilemma.
Yes, central lateral dilemma, no? Because it's very difficult to preserve the volume of the peri-implant papilla.
And also, according to the anatomic scenario that you have to deal with, is a completely different story. And you will see 3 different cases, completely different one to another. Starting with this lady, 32 years old, she just underwent 6 years of ortho, and this is the final situation.
So here our effort is try to compensate the natural resorption, 3D resorption of the hard and soft tissue.
So ortho here was not an option, not even for an ortho extrusion. So, and what was difficult here was to get the patient on board. Because the patient, as I said, 6 years of ortho, this is the situation. And she came with no trust in dentistry, with no trust in dentists, and with no trust of anyone, but she wanted the diastema closed.
And look the face picture, and look at the different level of peak papilla. From the two central, because we have diastema, no contact point, different level. No? Also in the right side, because the patient lost clinical attachment around the teeth. So different level of the papilla.
So here we have two issues. Engage the patient and educate the patient. Because the patient should understand the complexity of this situation. How to do it? Technology is the solution. Because you can start like smile designing the case just in order to explain and also to learn yourself from it. But also
today we have different types, no?
Today we have like many different types of smile apps. Back then we did not, because it's an 11 years old, but we had like the first DSD. So we were drawing lines. And this is the exact same slides that the patient saw 11 years ago.
And the patient understand. You design several lines, and the patient understand the real situation.
Where
before starting.
Which difference about the gingival symmetries, the teeth disproportion, and especially the uneven of the two papilla between the central and laterals. And the patient wants to close the diastema, so we need to explain to her, okay, you want to close it, we are going to save number 21 and number 13, we are going to remove 11 and 12, but we need to take in the prosthetic project 21 and 13 in order to close the diastema and to manage properly better the space.
How many teeth we have removed?
2.
Only 2?
Only 2.
Only 2.
Not 4, like they were telling there.
Not 4.
But let's see how it was. So, of course, traumatic extraction, but that was easy. So be kind and be gentle on the soft tissue. And the decision making was to place an implant on the central incisor and immediately load it. Why immediately load it? Remember, the mechanical support and the sealing of the gap that the provisional restoration offers us.
Yes, we prefer to place one single implant because the patient had a low biomechanical risk profile. So one single implant, and try to manage better also the peri-implant papilla.
And how to manage the peri-implant papilla prosthetically. Because you need to leave the space. You need to properly manage that central lateral shape. So you leave the space. You design, and you have a prosthetic project, so before placing the provisional restoration on implant.
Yes, in one single appointment, you place in perfect position the head of the implant in the central incisor side area, and manage the provisional restoration to reestablish also the contact point. Reestablish so the correct position of the papilla.
And to do that, we just print the mock-up of the veneers on number 21, so then we were able to reestablish immediately the diastema that was one of the patient requests.
Obviously, to compensate the soft tissue resorption long the time, we manage a soft connective tissue graft at the level of the vestibular side portion.
And a dual zone bone grafting as well. So we needed something that was supporting the papilla, but also sealing what we were packing into the gap. And here you see how the provisional restoration is getting into the socket and squeezing out the excess of the bone graft and maintaining and not choking the papilla between the central and the lateral.
Yes.
That actually was the key.
Because the provisional restoration has two main characteristics. Support the soft tissue, but also seal the socket. Seal the socket to protect the blood clot inside the socket, to avoid the bacteria going inside the socket. So not only design a correct profile of the provisional restoration, but also polish and clean the surface of the provisional restoration before deliver to the patient.
So the buccal palatal contour is there, the root profile is there, but what we care about the most in this case is the interdental papilla is there, which is maintained simply by the provisional restoration management.
So in one single appointment, you try to manage everything. So combine the prosthetic characteristic aspect, surgical aspect, mucogingival aspect together.
Digital.
And then wait for 4 months to the healing, and we have the technology.
Digital impression, copy-paste.
Copy-paste, digital dentistry.
Even 11 years ago, because that was a short span implant bridge, we could have managed it. Back then we had some limitation with technologies that we don't have today. And this was, let me go back, this was the final restoration, and you see the white and the pink is there, but what about the long-lasting predictability?
Andrea, probably we deliver too much connective tissue grafts to the patient.
Too thick.
Too thick.
Your fault.
My fault.
But we will see that the connective tissue graft augmentation should be no more than 1 millimeter in thickness, because then it grows over the time if it is a wide, thick, and dense connective tissue. So that's a good tip that Alessandro just pointed out.
And look at the level of the papilla, the different level. We maintain the different level of papilla. Remember, the canine, the right side canine, lost attachment before started.
What is nice to see long-lasting predictability. Look at 11 years. Hard tissue is there, soft tissue is there, and probably the only thing that if you look carefully to this image, you might see a little bit of infraocclusion.
Yes, and so be careful when you treat a young patient. Wait to place the implant in young patient. And also, we notice the different length of the central papilla, diastema and no diastema. The contact point is very important to recreate the hypertrophic portion of the papilla.
So that was one option. This is one option to treat a central lateral situation. Then there is another option which we can proudly present thanks to Maurice Salama case that offered it to us for this presentation. You see, you leave the root, and I'm sure there is a guy from South Africa that is going to close the day today, is going to speak about this approach. And you see, he extracted one tooth, he kept the root on the lateral just for maintaining the root profile, but also the interdental bone peak, and they were able to finalize the case, and the papilla is there. So that could be another possible solution. So remember, we are talking about solutions, so this could be another possible solution. What about the third solution?
Place to implant? No, not place to implant.
No.
No place to implant.
Still no place to implant, because place to implant probably is the most difficult thing that you have to manage. So if you have the opportunity to choose other solution, don't place to implant on the central, on the lateral. It depends on the anatomic scenario, but probably this case was not the right case, right, Alessandro?
Yes, remember, we have also the artificial peak papilla in the prost.
That could be another possible situation, because look here, 2010, this is a 25 years old patient that came to our observation.
Yes, not easy case, scallop. What?
We still have 5 minutes, because it was 7 minutes before, they cut it 5. Now 2 minutes, we're done.
2 minutes are done.
Yes.
Okay.
So here we have
scalloped clinical case, so thin phenotype. So re-establish the correct volume is not easy. So we wanted to perform one single surgery. Probably my fault. I did some mistake during the surgery. Go, Andrea.
And here you see first stage, healing, and second stage of buccal palatal contour. Everything is there. But look, the space was left also here. And now
yes,
the papilla is missing.
Papilla is missing in this case. So another surgery, or
gingival artificial pink component. Don't forget, we have a patient in the chair. So that could be another possible solution, because pink porcelain is absolutely a good solution to offer, because this is 12 years follow-up of this patient. The patient aged a lot.
Pink porcelain, over the top you can modify with the composite. Pink composite situation. Try to perform better the aesthetic result for the patient. The patient had an average smile line. So it's good the solution.
So take a message. One very important thing, optimal 3D implant placement according to the clinical scenario is the first and fundamental factor for aesthetic outcomes.
And to do that, it's very important, use the technology. So plan in the computer. Relax in your office, plan the position of the implant related to the bone and related to the lab project.
Whenever you have the chance, manage the soft tissue and the provisional restoration together, so you can easily sculpt the soft tissue, and the soft tissue will heal on top of the emergence profile.
Obviously,
that you have.
If you establish a correct volume of the hard and soft tissue, it's easier to design a correct emergence profile of your prosthesis.
Recipe. So which are the requirements for long-term success and to manage the nightmare of the peri-implant papilla? So implant position and profiles. We have discussed all of these aspects one by one during the last 50 minutes. Implant crown configuration, it's very important. There is no optimal configuration, but internal connection, it seems, that's the literature, it seems to be preferable, it seems. Platinum switching as a role. This is exactly what literature is telling us.
Appropriate torque for crown screw stability.
And also the prosthesis insertion protocol. That's another important aspect. And we were discussing about bone level and tissue level, without forgetting one thing, that in the middle of our treatment.
Yes, in the office they want always the quarterback, and the quarterback is Alessandro, no? The quarterback.
The playmaker.
And manage the different department, no?
But then there is a more important person, which is the patient.
The important person is the patient.
So, having said that, we want to thank you very much for your attention. This is where we are coming from, Modena. Ferrari and food are our main aspect, and we are all inviting you and expecting you in our hometown to give you and offer you unique experiences. Thank you very much.
Thank you very much. Okay. Thank you.
Thank you.
As an appreciation, here are 2 certificates from Ritter and Adek.